In this video.
Yes, I can see a child who is of nearly 8 to 9 years old child, well alert and well grown for age. She's in the hospital settings and connected to the monitor. The oxygen saturation was showed full, like 100% oxygen, and breathing rate was 113 beats. Sorry, heart rate was 130 beats per minute. So and the child is having rashes all over the lower limbs, and this is looks like a non blanchable purpura. So by seeing the child, and it is most likely in the dependent parts of the body held by the gravity. So my most likely diagnosis, this is HSP.
Yes, so I can say here a child who is stable, average for age, the child is not any distress, active, and the child on hospital setting, monitor is attached. And what I notice that the child has rashes, especially the rashes on the lower limb and distributions of the rashes. These are non-blanchable. So on top, my diagnosis Hanascolin purpura. A differential diagnosis you can keep like idiopathic thrombocytopenic purpura, non-accidental injury, drug reaction, COVID, leukemia, sepsis, and DIC. Okay. So what history will ask?
Yeah, I would like to ask about the onset and course and duration of the disease, and what are the associated factors? Is it associated with fever, weight loss, or recent weight loss, or activity? And what about the activity? What about the sleep of the child? Any associations with lymphadenopathy? Any history of recent travel, and any urinary symptoms with this? Yeah.
So that is rash. So and we keep our DD and our diagnosis. So first also course and duration, what make it better, what make it worse. Then the rash distributions like rash when started, about its distributions, and there is HSP is our top. So HSP feature we keep in our mind. So AD abdominal pain is severity, blood in the stool, intersusception associated with that. Then joint pain, arthritis also present. Arthritis, their number, their fruity urine and its color, proteinuria present amount. Anyone measure the blood pressure, hypertension present, pain and redness on the private area if male child, there is orchitis present. These are Henascolin purpura. We keep other features like ITP on DD. So, is there any bleeding on any other side of the body? Non-accidental injury. We can ask like the family register to the social service. Anything suspicious happened? Drug reaction in drug taken before that. The leukemia. So, any abdominal distensions, hepatomegaly, splenomegaly is such. The child is fatigue, fever, weight, activity, sleep. Here, sepsis like the child is active or lethargic. Any morning headache, neck stiffness. So these are any abnormal gait, headache, seizure. So what examination you do? Suppose it is Hanascolin purpura.
Yes, I would like to ask about the yes examination. I would like to check for the air patency of the airway, breathing and circulations, and complete abdominal examination of the child, and any asking the like checking the vitals of the child,
Hmm.
and
So
for
any examination
neurological
first.
examination, cardiovascular examinations.
Why cardiovascular you are taking here? CVS needed. No.
Oh, no, 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 not cardiovascular.
MSK, musculoskeletal can come because arthritis is one of the feature of Hanascolin purpura. You keep
Yes,
in your
yes,
mind,
yes.
you when tell HSP is my top diagnosis, so HSP related system, then it will be easy. First, airway breathing
GIG,
circulation, any examination
yes.
with airway breathing circulations, vital, especially the blood pressure examination of rate itself with glass test, non-blanchable. During ABC, we see that child stable, any abdominal pain present or not. If pain present, so what is the main pain score? Neurological examination we can do, MSK examination, abdominal examination for lymph node to exclude malignancy. What investigation we do?
Yes, initial investigations, full blood count, blood film, and also regarding this urea and electrolytes and kidney function test and urine microscopy for any hematuria and BP. First of all, vitals, especially BP and urine dipsticks to check for the hematuria, proteinuria, and protein creatinine ratio early morning.
Yes, yes. So we start from bedside. Bedside, what we do? We do the blood pressure and urine dipstick. If proteinuria, send urine for early morning protein creatinine ratio. If hematuria, urine microscopy. So bedside, we have two tests we are doing: blood pressure test, urine dipsticks. They ask masculine purpura history, blood pressure, urine dipstick. Urine dipstick, if I proteinuria, I find then morning urinary protein creatinine ratio I do, and hematuria, I find then urine microscopy. Then for urinalysis, abnormal diagnosis uncertain, we do the full blood count, blood film, urine electrolyte, albumin, if fever, blood culture, AST, and coagulation throat swab. Pneumatic fever they're also keeping there because here features of upper respiratory infection present, throat infection present. So what management you do?
Yes, I would like to manage for the symptoms. First of all, will stabilize the patient regarding airway, breathing, and circulation, and then I would like to start if the pain, if she's having painful joints. So I would like to give this ibuprofen for this joint involvement and abdominal. If she's having abdominal pain, so I would like to start with the prednisolone 1 milligram per kg per day for 2 weeks. If yeah, and monitoring of the child like for uncomplicated HSP, urea electrolytes, and follow up with the GP and BP monitoring.
Okay, I'm telling management. First, a Hennescreen purpura patient come. I take the full history, examination, investigation. I already done. So it is HSP. First, I'll tell that I will admit it or not. For admission, there are some criteria present, like orchitis, moderate to severe abdominal pain, arthritis involving more than two joints, proteinuria, GI bleeding, inability to ambulate. So these are IMC. So if it's indication of admissions or otherwise not. So joint pain, I give the NSAID like ibuprofen, but it's renal patient, then with caution I will there. The abdominal pain, if severe and persist, exclude the pancreatitis, intersusception, or spontaneous bowel perforation. Prednisolone for 2 weeks. So main treatment are NSAID and the prednisolone. If severe abdominal pain, I exclude the pancreatitis, intersusceptions, or bowel perforation. These are associated with that. And indications and follow up like in uncomplicated Hescolin purpura. So if uncomplicated, that is urine analysis less than equal to 1 blood and protein and normal blood pressure. There is no less than 1 or equal 1 blood and protein, that is proteinuria, hematuria, and normal blood pressure. No hospital follow up required, but GP follow up for up to 1 to 2 weeks. Monthly blood pressure for 6 months and weekly urine dipstick at home until urine clear. So 6 month blood pressure I will monitor and 1 to 2 weeks GP follow up uncomplicated Hennescreen purpura. But Hennescreen purpura with hematuria and proteinuria more than one and normal renal functions as above and routine follow up for children in OPD. Children OPD he will go. And when I
Okay.
refer nephrology, some nephrology, rheumatology, we will. Nephrology, urinalysis and blood early protein creatinine more than one after 6 months. After 6 months, it is more than one. Proteinuria, hematuria. Then macroscopic hematuria or heavy proteinuria at presentations. Hypertension, significant proteinuria, early morning urine, protein creatinine ratio more than 100 gram per millimole or 3 plus proteinuria for 3 days, impaired renal function. So nephrology we are taking after 6 months, high blood pressure, hypertension, more than one proteinuria and hematuria after 6 months. Then severe microscopic hematuria or proteinuria at the time of presentations, inability to ambulate, and there is protein creatinine ratio more than 100 gram per millimole or 3 plus proteinuria for 3 days. Significant proteinuria, actually many proteinuria, hematuria we keep in our mind, and refer to pneumatologist when there is atypical rapidly evolving rash. And some advice and red flags we keep in our mind. First, may fluctuate for several months, but recurrence is rare. Very risk of recurrence, renal failure 1 to 3%. They ask that in history. Renal failure 1 to 3%. Seek medical advice if the child has headache, rectal bleeding, severe abdominal pain. So headache, rectal bleeding, severe abdominal pain. It also comes on communications. In communication at the end we tell some red flags. Hematuria, severe abdominal pain, then rectal bleeding, headache. So this is all about Hennescreen purpura. Next we are going.
Okay.